This is Fam Electric Ghost. We're talking to Julie Siemers.
Siemers.
Siemers, sorry. But we're talking to you for the first time, and we're going to talk to you about patient safety. You're like a visionary nurse leader and transformative educator, and I want to welcome you to the Fam Electric Ghost podcast. So one of the things we ask every guest before we get started into the heart of your story is like, what motivates you, and why do you do what you do?
Well, I've been a nurse for 46 years, and I'm not quitting anytime soon because it has become clear that my passion and my mission is to prevent patient harm by informing and educating patients and their families and nurses.
Yeah, well, it's good to pay it forward with from your life experience. And so you've written a book as well, right?
I have, yeah. Surviving Your Hospital Stay.
Yeah, I think I have it right here. This is the full title.
Yes. Mm-hmm.
So Surviving Your Hospital Stay, a Nurse Educator's Guide to Staying Safe and Living to Tell About It. And that's, I think it's important because just kind of disclosure, I was a cancer patient when I was 27, had like a level 3 sarcoma, went through radiation, multiple surgeries. So there was a lot of stuff I had to educate myself about.
Yes.
In terms of what I needed to know as a cancer patient. And being 27, you probably think you're going to live forever. There's a lot of stuff I didn't know. And I luckily I was college educated, and I actually dove into, I need to understand what's going on. But sometimes you need to kind of have, I think, some information. And what you're saying is you need to check some stuff for yourself, right? Not just trust what's going on without doing some research on your own, right?
You absolutely do. The more informed and educated you are, even before you plan on going to the hospital, the better outcomes you're going to have. So understanding that patient harm occurs is the first piece of awareness. But where I have hope is that we have solutions. We can turn around this trajectory that we're on of massive amounts of people dying from preventable patient harm every single year.
Is it because doctors are overworked and the system's kind of tapped out, or is there a combination of other things?
That's definitely a big part of it. And yes, there are other things as well. I like to say that yes, humans make mistakes, but systems errors. So healthcare is very complex. And when you line up enough things that could go wrong, that do go wrong in systems, that's when patient harm occurs. So for example, when the nurse a couple of years ago, it was all over the news, gave the wrong medication that killed a patient, when we go back and do root cause analysis and try to figure out what happened, they found in this investigation in particular about 10 different systems problems that contributed to that error. So when we do the research, just like the National Transportation Safety Board, every time an event happens with the aircraft, yeah, they grounded, I think it's going on almost 2 years now when the Boeing 737 blew off midair at 16,000 feet. They found it was a faulty bolt on the door, which by grounding the aircraft and doing the investigation, they found it. But we don't do that in healthcare.
Oh, so they don't have like an after action. Like in a lot of times, like I'm a software guy and we have lessons learned and we go through the project and we go like, what could we have done better? What went wrong? And we really kind of looking glass self for the whole project, dive into like, was something wrong with the algorithm. There's something wrong with the inputs. There's something wrong with the foundational structure. And we don't take it personal. The programmers and the architects is like, hey, if I made a mistake, I need to know. So is it a structural problem where they're not wanting to do that deep dive?
So some hospitals do, but it's not uniform across the country. It's not federally mandated. We don't have a national patient safety board. And so the mistakes get kind of swept under the carpet. And I call it the Wizard of Oz curtain of healthcare. We don't really know what's going on because there's not mandated reporting. There's not transparency. And if a hospital gets sued, there was a report or a study done not too long ago that said 80% of those hospitals that settle malpractice suits require the patient's family to sign a non-disclosure, an NDA.
Yeah. So I mean, it seems like if you do the deep dive, are they scared that some lawyer is going to get that in discovery? And the
Yes.
reason they're not doing it, because my brother's a lawyer, and it's like, oh yeah, you probably don't want to create a whole set of data for these lawyers to get. So you don't want to do it, because then they're going to grab it. They're gonna go ask for it.
Right.
So I mean, that's probably what root cause analysis is. What anybody looks at, like, why is it happening the way it's happening? But yeah, it just seems like, so you're trying to tell the patients to really take some responsibility, maybe not just like put their hands. Yeah, they say, oh, I don't know. I mean, I just maybe trust but verify.
100%. And nobody ever gets into healthcare, whether it's a doctor, nurse, pharmacist, radiology, tech, whatever. Nobody ever gets into healthcare to harm a patient.
Yeah.
But unfortunately, we become a part of this system. But again, I think it really comes back to the hierarchy structure that we have in this culture, where the doctor's on a pedestal because they've gone to 12 years of medical school. And we put, as you said, complete faith in, hey, we're going in the hospital to get our hip replaced, or, because we've had a heart attack. But the risk of going in the hospital is things that people just don't think about. So my mission is to help them think about those things before they go in the hospital. For example, if you understand that 1 in 31 patients in the hospital acquire an infection from being in the hospital. So then when I tell you one of the best ways to prevent spread of infection is everybody needs to wash their hands.
Yeah,
And yet,
that would be simple.
yes, and it is simple. About 50%, it would drop the, transfer of infections. But people are afraid to say something. So here's what I say. If you knew that when you just said politely, can you please clean or sanitize your hands before you touch my father? Oh yeah, let me go do that. Or I did it in the room before I came in here. That's fine. That's great. But I would please like to see you sanitize.
You want to see it now. Yeah.
Well, and when you know the consequence of not saying something, your dad may get an infection that kills him or keeps him in the hospital for another 2, 4, 6 weeks, right?
Yeah, I mean, that's a really important thing, because also my wife is undergoing, she's got smoldering myeloma. And so she's under her immune system is highly compromised. And so we've been very, very cautious, and we in our health record, we demand that people wear like N95s.
Yeah.
Right. And we demand a hand washing, and we've been able to keep her from having unnecessary infections and complications. And it's really interesting to me when you get like nurses and people, they push, it's like, don't you have a degree in biochemistry? And it's like, why are you not understanding that I don't want to get infected if I don't have to? Right. I don't want to get COVID if I don't have to. Right. I don't want to get like neurovirus if I don't have to. Right. So if I ask you to wash your hands, ask you with an N95, what's so hard about that?
Yeah, there is a lot of pushback, unfortunately, but I'm also trying to help people bridge the gap. I gave a TEDx talk. It came out in January, and the whole message was to prevent patient harm, we need to communicate better, because 70% of patient harm has been linked to communication breakdown. But that communication is between patients and families and the healthcare team, whether it's between 2 doctors, a doctor and a nurse, a patient and the nurse, a family member and the doctor. We just need to bridge that gap so that, for example, if your wife's in the hospital or your mother or somebody, a lot of times we assume things based on a few facts. For example, if your mother's in the hospital and maybe she's 80 years old, and she's confused, and you're telling the nurse, hey, something's wrong with my mom. And they're like, what do you mean? Well, she's not confused normally. Even though she's 80, she's with it. And not having you to be there to give the baseline of what your mother's behavior is normally like, they would assume she's always confused and not look for the factors that are creating this confusion, whether it be low oxygen, low glucose or blood sugars, or electrolytes, or something going on neurologically. So that's why patients need to speak up in their families.
Yeah, I know that's really important because my father, like he's not here anymore, but he died from Alzheimer's,
Mm,
and he had a habit when he went to the doctor of saying like, not really telling them what was going on
yeah.
and saying point blank is like they're the doctor, they should find out. And so like we had a really hard time, and my mother had to end up going, and sometimes I had to go to actually tell them what was really going on because he would not speak up.
Yeah.
And sometimes you have a situation where you have a difficult patient and you do have to have somebody else help because they won't do it. At
Yeah.
least my father, he was a good example. He would not actually relay what was going on.
Yeah, and you bring up a really good point because so many patients need an advocate with them. Not even that they have Alzheimer's, but if they're in acute pain, if they're so sick they can't answer questions or give enough details to help the healthcare team figure out what's going on. So, really important.
Yeah, because it's like sometimes it's like the simple things like you're saying, assumptions.
Yeah,
Like if people assume, then it's not a good situation because you really need to have all the facts.
yeah,
And being a guy that deals with data is like I need to know all the variables. And I would think if a doctor and a nurse know the whole picture, the holistic picture of who this patient is, what's going on, the more information is gonna be the better. But is
yeah.
there other situations where they don't actually listen? Like if somebody's giving the information and then they're like, oh, they kind of just want to skip it and go right to what they want to do. Is that another communication problem? So even if you try to give them, they don't listen.
Many times that is true. And that's why I need to work with both ends of the team. And when I teach nursing students, I taught class last night. I said, your patients and your family members can give you such important information, even if it's asking you the question, hey, what pill are you giving my dad? Oh, well, I'm giving his blood pressure pill. Well, that's not the one he usually takes. It doesn't look like that. Are you sure it's the right medication?
Mhm.
Or the other nurse already gave it to him, and so it really opens the door. And I think being receptive on both sides. And yes, I'm not expecting family members to have a nursing degree or a medical degree, but even being informed enough to say, what test are we doing? What are the results? And what does that mean to my family member is a good start.
Also, like all the options, because I remember when I was a cancer patient, I was given a bunch of options, and I actually went into looking at it because one of the options was to go into experimental chemo.
Mm,
And then they told me it was a 50% chance I would get a placebo, but I had aggressive sarcoma. And then I thought to myself, like, well, if there's a 50% shot that this chemo is not actually even going to do anything, and I've got an aggressive sarcoma, if I go with that, my sarcoma could metastasize. So
right.
I said, I actually went and got a second opinion. It's like, is that actually the best thing to do with this level 3? And they said, no. And so I said, so because I just didn't trust the first doctor I went to, I went and got, I actually went and did some research too, but not everybody knows to do that.
You bring up a really good point. Second opinions are so important, especially if we're talking about life and death situations. I use the example of surgery. There are some surgeons that will do 2 to 5 surgeries of a certain kind every year, and others that'll do 200 or 300. And if you don't ask the surgeon, how many of these procedures do you do on an annual basis? And what
Mhm.
is your success rate? They're never going to tell you. But I know for a fact myself, I want someone who's done 200 of them every year.
Yeah, you want them to be a master.
Yes.
Everybody knows, mastery is like 1,000 hours, 10,000 hours. The more you've done it, then you're probably closer to that 10,000 hours. If you can, maybe that's something people wouldn't want to reveal. Like I haven't done the 10,000 hours, right? So then you're like, well, maybe I don't want this guy.
Exactly. It's your body, it's your life, right?
Yeah, yeah, that's things that people might be saying, "Whoa," they're gonna get upset that I'm asking that. So, well, he's like, you're the patient, like, you're paying your insurance premium, and it's like, so shouldn't I have some level of customer service?
Yeah,
Like, when you go to get your Lexus work done, you're willing to go ask a lot of questions, right? But
that's
then when your body
exactly.
is like, you don't wanna ask the question?
To me, I use the analogy, maybe it's because I lived in Las Vegas for 22 years, but you're rolling the dice if you don't ask questions.
Yeah, I mean, because you gotta really start taking it serious in terms of, like, this is like you said, just like an ivory tower where a lot of times they're on the mountaintop and the surgeons, like, they're just perfect. But, being a musician, like, the perfection trap is always this thing. Like,
Yeah,
you run into people and really as you go, you gain artistry, you start to realize, people there's happy accidents and there's, like, mistakes.
yeah,
And so, like, what nobody's perfect. So then you do have a right to kinda ask those questions. Like, well, how many what's your level of mastery? What are the options?
yeah,
Is this
and
the
you
only
should.
thing, you know?
One other thing I would like to offer to your audience, not many people know about this either, but I think it's really important, and I talk about this in my book, is choosing your hospital. They're not
Mhm,
all the same. So there's a website, hospitalsafetygrade.org, where
mhm.
you can go on, put your zip code, any state in the US, and you can find the hospitals in your area and see their safety grade A through F, just like college or high school papers. A means, hey, excellent work, and F, not so good, you're failing and flunking, right?
Yeah,
So
you're
there's
like
32 quality and safety indicators that go into creating that score. I was talking to an attorney about a month ago about my nonprofit. She was helping me with that. And she said, oh, she's 7 months pregnant. And she looked it up. She said, my hospital I plan to go to have this baby is a C rated hospital, but there's an A only 30 minutes further. I'm going to that hospital.
yeah, that's important, and also, like, you also have to kinda know, can you do the same thing with, like, your primary care physician? Is there a way to get a rating for them? Because 'Cause they're,
It's
like,
a,
outside the hospital system sometimes in these, like, networks of primary care providers.
it's a little tougher. A lot of times you'll see billboards for physicians, which they pay for. So know that, or being on magazine covers. Just know that again, that's paid for. There are sites, and I talk about this. I've got an app for patients and the families that is coming soon, and I talk about how to choose your physician there. There's websites where you can check and see if they've got any um, negligence or malpractice on their license. That's a really dicey area too, because the American Medical Association really stands behind doctors, sometimes to a fault, I believe. For example, a doctor can harm a patient in one state and have his license revoked, or then he can go to another state. Should they be looking to see this guy's
Oh,
history?
the state history. So is that an issue? Like, if you look up for a doctor, is like, are you only gonna get your state? Are you not gonna get their whole record? Like, if they were in Vegas or they've been in California or they've been somewhere else and you're in Massachusetts and you have no idea what they did in Vegas, but maybe
Yeah,
they got kicked out of Vegas and you were like, "Oh,
right.
what happened?"
It's yeah, it's really difficult. There was a medical malpractice case a couple of years ago, and it was in Las Vegas. A woman who had her second baby and ended up being discharged home, but she had an infection on her heart valve. And
Oh,
so the increased heart rate, the elevated white count, the signs of infection were dismissed and ignored. She ended up dying. But then come to find out when they did the research, this doctor already had 3 different lawsuits for different things, but in his specialty in obstetrics or delivering babies. So most people just don't think that they should, do a little research before they choose a physician to care for them.
yeah, you really have to kind of trust and verify, but verify because, if it's not gonna be like readily apparent. And that maybe this is the consumer kind of advocacy thing, where like you need to have full disclosure, but the disclosure is kind of a couple layers back and you got to pull the onion back. Like, people might not do it.
Right.
Right. And so it's like, if it's harder to find that information, you can say, well, like maybe they're protecting each other, but it's like, how do I protect myself?
Right.
Because that's always the rub, right? Because you're like, it's not usually going to be, they're not going to just throw it out, right? So it's easy to find, right?
It isn't easy to find. You're exactly right, which is all the more reason to take some time, research your hospital, research your physician, especially if it's, a major life illness going on like you had, or major surgery coming up.
And also, you have to be an advocate for yourself, and sometimes you have to push against your plan. Because like
Yes.
your doctor could say, you need to do this, right? You go get a second opinion. It's like, yeah, I really need to do it. Then you go to your plan and they know we don't cover that. And then you're like, well, I really need that. So then it's like, well, you got to pay out of pocket. So then there's a whole thing of sometimes with these plans, if you go and appeal, they will do it. And they're hoping that you won't. So you always have to go with the appeal, because if you push, sometimes they cave.
100%. And we're seeing more and more of that, especially with the light that was shed on the problem at a national level when the United Health CEO was murdered last year.
Mm-hmm.
Again, this is a customer who was completely frustrated. I'm not saying he's right, but he was completely frustrated by the system and the denial, the delays, which is why that happened. But we're seeing more and more of that. We're also seeing in that realm the application of using AI to determine if they're going to do denials or approvals. And so you're exactly right. They don't expect anyone to push back and appeal. And sometimes you may have to do it 2 or 3 times, but keep fighting for it. And we do. We need to change that system. That healthcare should not be for profit, in my opinion.
Yeah, I think there's a big problem, because the reason we're getting these denials, because I work in IT and I work in insurance, and I've worked in the leg that's in the health insurance. And the biggest thing is like they're making a profit because they're denying service.
Right.
Like they're denying claims. I actually have built systems that do that thing, right? It's like they're doing it because the actuaries want to see a better bottom line. Right. So they're going in and they're doing calculations to say, if we deny, we get a higher profit margin. And if somebody goes and we put them through the hoops and take them 3 months to get an appeal, some people won't do that work. So we're depending on that. And the AI is just automatically, a lot of times with AI is like, it is kind of designed to make it harder for the consumer. Like they tell you it's being done to make it better, but a lot of times it's a layer to keep you from. You get a level of disgust and you tap out, you get out. And you do.
Yeah, I did a social media post a few months ago about one physician who actually worked for one of these insurance companies, and she became a whistleblower because she said, "Here's what's going on behind the scenes." And she spilled the tea on this insurance company outsourcing claims to nurses in the Philippines. And then because they're lower cost, and then the insurance company told the physicians, don't argue. You just need to stamp of approval what the nurse in the Philippines told you to do. And she's like, I can't do this. There's no integrity here. There's no total lack of ethical work.
That's when
here.
profit becomes like profit is if it's its own goal.
Right.
Then when you end up being a whistleblower, when you actually say, well, aren't we supposed to do no harm? Aren't we supposed to actually, if the outcome says we have to spend more money, don't run it up the chain and say, hey, well, this guy says we shouldn't spend X amount. So every time we spend X amount, we send it to this director, and the director does his override and hopes to push it down. Well, is that doing no harm? It's like, what are you doing? And so like I got out of it because I was in it for a while, and I just didn't like the tasks they were giving me. I was given these tasks to build these algorithms and do stuff, and I started looking at like, what's this thing doing? This thing is not really helping people. It's
No.
helping certain people, but it's not helping other people. And
Yeah.
I went into something else. I actually went into reinsurance and more property casualty stuff. It wasn't like about somebody getting health care, because to me that's life and death. And I'm like, I didn't like it. So I got out.
Our healthcare is broken. It is extremely broken. And I'm not trying to be negative or throw my own profession under the bus. But the reality is that we as consumers of healthcare have to become aware, informed, and educated, not only to help change the system and the culture, but to stay safe. I want to see
so we need better outcomes. If you look at like our country, like I lived in Japan, I've lived in other places, but you look at our outcomes, we pay a lot of money and we have really bad outcomes.
Yeah.
So it's like, why are we paying so much money and having such bad outcomes for people? You know, in terms of like maternal, like the issues with like African-American women in childbirth, they're having really bad numbers compared to other places in the world. And you're like, why is that? And if you look at other numbers, it's still like on this bad trajectory. And like we pay the highest premiums of any country for bad outcomes.
Yeah. Of the top 10 countries, we are number 10. We're the worst of all 10.
And a lot of people wouldn't believe that. I mean, if you tell them that, they'll say, oh, that can't be true.
We have the best technology, but we have the worst outcomes, as you said, maternal deaths and infant mortality, et cetera. It's, well, and patient harm, you know. It's
right, because it kind of goes back to like, if you think greed is good, like that old Wall Street movie, if you let private equity run the show, you know, they don't
100%.
always do what's actually good for the economy. They'll take a business and run it into the ground and get rid of it and take it apart and make money off of it. And then does that serve the consumer? Does that serve the society? Well, you know, this guy went bankrupt. These workers are out of a job and the rates are gone up. So a lot of times, like, it's good for your portfolio and your 401k. It might be good for your stock portfolio, but it's not good for your overall Main Street. So like you start to have to balance out, like, what are we looking for? Are we looking for everybody to be taken care of medically? And from a health point of view, do we want better outcomes? I think we'd have better GDP if people are healthier.
For sure. Absolutely. And there's been several of those private equity companies that have bought hospitals and, like you said, run them into the ground. They decrease the salaries, they decrease the staffing, they decrease supplies, and patients die. So it isn't for our good. It is to line their pockets with profit. So I think we need to separate that too. Hopefully someday we'll have some legislation that pops in and says, this is harming individuals. And when we harm individuals, as you mentioned, we harm the whole country.
Yeah, because it's like the argument has always been like, you got to let greed go because it's going to eventually help everybody. But when you really look at it, like from an economic perspective, and you do the actual work, you actually see that if you actually make sure people are healthier, the economy will be more efficient. People would be working to their, like, actualizing to their best selves.
Yeah.
But if you don't allow people to have a basic level of health, then like your productivity could go down, your efficiency's down. So the overall GDP is like, it's the opposite of what you think. Like if you actually gave everybody good healthcare, the GDP would go through the roof. But like you have this idea, like if I let this guy just like be able to get this much money, and this group of 1,000 people, 10,000 people will get to this much money, then somehow that's going to trickle down to everybody. Yeah. It's never been true. It wasn't true in 29. It's not true in 25.
Agreed.
But I think it's like, it's about like this deciding, like looking at the big picture, because this is all part of a kind of a big picture. Like you can only take care of yourself.
Right.
So you look at yourself, you start with the individual. But then if you get like, if you be a patient advocate, then you might get with other groups, you get with other people and say, hey, I was working on myself. And then I say, hey, there's a lot of people have the same thing. Maybe you get collectively start coming together and say, hey, maybe we should join a patient advocacy group or join this group. And it goes from being you to being more than you.
Yes, exactly. It is the power of the collective is stronger than we remember because it has worked in the past, and we need more collaboration between like-minded people that really have a mission to help and to heal, really.
Yeah. I mean, because if you deal with, like in the both sides of it, you got the doctors and you got the patients. And if you have a conversation, you have communication between the doctors and the patients, and you have this idea of like, we need to have this safety. But it's not just on one side tilted to one side or the other. It's like everybody needs to communicate.
Yeah.
And say the overall goal, right, is to have patient safety.
Yeah. And like I said earlier, nobody plans on harm, but when we know how it occurs, and we do, whether it's diagnostic errors, healthcare acquired infections, when we apply the principles to, let's just say, enforce hand washing or make sure there's a terminal clean when a patient leaves a hospital bed so that there isn't any, infection spread that way. And we do it together, we can make those changes, and we can impact how safe our hospitals and our healthcare system is.
It's so basic, the idea of a clean room,
right?
Or a clean like tools. But you can see, like, if you get overbooked, you don't have recovery time from one patient coming into the next, you don't give the cleaning staff enough time to do it because you're just like, oh, we got to move people around like they're widgets on an assembly line, versus like, are you doing it right every time? What's being measured? And it probably a lot of times goes back to who is running the company, who's running the hospital, who's running this collective of doctors. Is like, what's their primary concern? Are they concerned about the patients having a clean room and clean tools, no infections? Or are they concerned about like how many beds I'm filling?
Productivity.
Yeah. So it's like how do you get people to change that dynamic? And we're in a system where like really profit is king. It's kind of what, if like that's what they think. But he's like, again, the efficiency situation, if you've got the overhead of like, you got lawsuits, like if you get all these lawsuits because of what you're doing, are you being as efficient as you think you are?
There's a big study that was done several years ago across the nation. The average that a hospital spends on patient harm every year is 13 to 15% of their annual operating income. Mm-hmm. I looked up a hospital just because I was curious. I'm like, I have no idea even what their annual operating income is. And this was one hospital in Austin, just because I was living there at the time. It was $88 million. So let's be really conservative and say, okay, they only spent 10% this year, not 13 to 15%. That's almost $9 million on patient harm.
That's a lot.
Yeah.
Yeah, it seems like you need to kind of start opening your books as an actuary.
Yeah.
And say, if we did a better job, that amount we're paying out is going to go down, and maybe we can spend that on actually doing better care. Right.
Yeah. And, CMS, Center for Medicaid and Medicare Services, implemented several years ago penalties and rewards, if you want to call it that, reimbursements for good care. So the higher the infection rates at a hospital are, the less reimbursements they get, and it can even turn into penalties. So apparently it's not an incentive, a high enough of incentive, because I think there's some workarounds. In fact, I read a research article recently that said some hospitals are not testing for infections, so they don't have to report them. And I thought, no, this can't be happening. But I did a social post on it, and I cannot believe the amount of healthcare workers that responded and said, yep, If we have a patient with diarrhea and the doctor orders a C. diff, we're not allowed to do it unless we get cleared from our manager. And I said, what? But there was enough of that it's happening, unfortunately.
Well, sometimes it's like you think about, you go back to the, like what happens with products, right? Like you had the Ford Pinto back in the 70s, and the actuaries knew they had like a bad gas tank and they exploded.
Oh.
They knew it was bad. They knew it was a bad design. They said, they calculated what the lawsuits would be, and they didn't pull it off the market. They didn't fix it until they got sued really hard, because they said, well, we can survive with that level of a problem. So sometimes it's like, well, how can you make a decision like that? But then you wonder, like, when you get people who they're looking at a spreadsheet and then they don't think about the number behind it as a person. They just look at it as a number. Then you can kind of detach yourself.
I'm glad you brought that up, because one thing that I feel so passionately about is we've got to bring the heart back to healthcare. So when a physician makes a decision to keep a 90-year-old patient on the ventilator and start dialysis, which this poor little old grandpa, it happened to me several years ago when I was working in the ICU, the moral dilemma that I had, I just wanted to cry. Please let this man die. What we're going to do is torture his body. And it was such an issue with me. I wanted to say to this doctor, if that was your father in the bed, would you still make that same decision?
Mm-hmm. Yeah, one is like, why are decisions are being made based on like these values in a spreadsheet without thinking about the human factor, the human value. And the more we get detached and more we get into the looking at the data analytics and looking at the red line and the black line and the bar chart, and it's like, oh, like this is what it's like. No, there are people behind that.
Yeah.
So think about the people.
Yeah.
So like when people go to your website, is they're introduced to your patient safety checklist and also your book?
Yes. And I have I've done quite a few blogs over this last year and a half, so all those articles and references are there. I keep adding new stuff to help patients and their families, so all of that they can find on my website. And I see you had the socials up there. I have the TikTok and the Instagram and Facebook to, again, just educate people to even be aware that this happens and what they can do to stay safe and help their family members stay safe. Even if it's one patient's life that I help contribute to saving, then I have done my job here on this earth, which it's already happened. My goal is to save 1 million lives.
Mm-hmm. Well, that's a really positive thing, because a lot of times people are like that. Their goal isn't about saving lives. Their goal might be something else. And when we have people who are actually like, I want to help human beings, that's always a positive, place to be. And I want to again point out that we do have that QR code. That QR code actually maps to your website, the Dr. Julie website there with the patient safety link. So if you take your phone and you scan that QR code, it'll go right there. So people can do that quickly. And you can click on the link once the podcast is over. It's just not active right now.
And when on that website, you will see the app coming in just a couple of weeks. So stay tuned and come back to it, because I think it really will provide patients and families. It's the book put into an easy formula of modules of learning of what is safe medication administration, because that is the second biggest problem in hospitals is medication safety. So if you understand that nurses are taught in school 6 rights of medication safety: the right patient, the right drug, the right dose, the right route, like if it's supposed to be given orally or IV, and the right documentation. So if there's a mistake made, we can trace it back to one of those. But many times you'll see nurses skip some of those safety steps because they're in a hurry. And there's been so many cases of patient harm or even death because the wrong medication was given or the wrong dose of medication. I just posted a couple weeks ago about a nurse that gave 20 times the ordered dose of morphine. She was supposed to give 5 milligrams, and she really didn't remember her dosage calculation and gave 100 milligrams, which killed the patient. But she said, "Oh, I thought milligrams were the same as milliliters." It was an oral solution. And so just asking those questions as a patient and family member, what are you giving my dad? How much are you giving? Can make a nurse stop and pause and do that double safety check that they should be doing.
Yeah, it seems like you got to have that kind of stop, slow down. Because a lot of times it's hard because we're all, everybody's told to go, 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 go.
Yeah.
Everything's so immediate. But when something's that important, you really need to kind of like, let's take a breath. Let's go make sure I go down my checklist. And even though it seems like, that's just academic. Well, it becomes less academic if you start skipping steps.
Right.
So it's like there's a reason why you have these safety checks. There's a reason why, like in engineering, people build things and say you've got this kind of like you go through a process, you go through like an algorithm, and it's got certain steps that have to go in order of operation.
Yes.
Right? And if that doesn't go within order of operation, then it's going to fail. Right. So.
Yeah. I flew on the helicopter as a flight nurse for 10 years, and I had pilots who had decades of experience. They still always pre-takeoff. Before we lifted, they're doing their checklist. Before we land, they're doing their checklist. They don't skip it.
Yeah, you shouldn't. When especially, like machines, people are more willing sometimes to like, this machine requires me to do X. I got to flip this switch.
Yeah.
Prime this, do that. But you got to still, like, no matter what the process is, if you've got a handbook, if you've got like we've got these like cheat sheets or what we call them, like operational stuff. You're running big machines and you have these books that say you do this, if this happens, you do that. And even though you've been doing it forever, you still have your book right next to you, right?
Yeah.
And you're still going to open that book. You've done that thing 10,000 times, but you're still going down the list.
Right.
The day you start thinking you don't have to do it is the day the bad things happen.
Yeah. In fact, we have a checklist from the World Health Organization for surgery, but not every hospital uses it. Sometimes the physicians will say to hospital leadership, it takes too much time. I don't want to do it. And for some reason, they're allowed to make that decision. But unfortunately, we still have things like wrong site surgeries, which seems insane and crazy.
That's crazy that you got the wrong part of the body.
Yeah. Whether it's amputating the wrong foot or whether it's replacing the wrong knee, those are never events. Sentinel events, never events, named by Joint Commission who accredits hospitals. But again, it just takes stop, like you said, slow down and do the double check.
Yeah. I mean, it's very simple, but the stakes are very high when you're dealing with human beings. I mean, like if I'm dealing with a machine, there might be a consequence to what that machine is doing. Right. But still, like with a human being, you really should be doing that level of do no harm. Like you should do no harm. You should that's the mantra. That's what you should do. And like no other reason is higher than that.
Exactly.
That's like the base
100%.
level of competency, like that. You do no harm. But I want to thank you for being on the show today. I think it's been really illuminating, and it gives power back to people maybe that feel like I don't know what to do. So now you're giving somebody a roadmap. Like this is what you could do. You can ask them to wash your hands. You can ask them like what dose are you giving me? Like, do you know I'm supposed to get this surgery is supposed to be here? Speak it out. Say it. Like, what are you doing going over there?
Yeah. I relate it to helping patients and families understand you can't be a passive recipient of healthcare anymore. Mm-hmm. Those days are gone. You have to be an active participant. And we are really lucky that we've got excellent research tools. But again, I just want to caution people. In fact, I was just posting on TikTok tonight that when people asked ChatGPT if they should call an ambulance, they only got the question right half the time.
You do have to be careful with AI. Like AI is not the end all. Just because it gives you answers that seem plausible
Yeah.
doesn't mean it's right.
Yeah. It's a great resource for not life and death medical advice.
No, like we've gotten in trouble with engineers, asking it tolerance issues or basic things, and they've gotten it wrong.
Yeah.
They've gotten, lawyers have been given wrong precedents and actually brought it to a judge, and the judge like look at them and like, where did you get this from? So it's like you gotta be, just because it's very convincing, it will give you an answer that looks better than an old Google search.
Yeah, that's true.
But you still have to look at it and it's like, is it actually giving me the right information? Because it has a tendency to want to satisfy the person who's asking the question.
Yeah.
And it will have what we call hallucinations.
Yes.
Where it will pull data that's not valid, but it actually tries to give you an answer. And it's like, it doesn't have the basis to actually do it, but it will still try it. It will still try to do it. And that's the danger with a lot of people today, young kids today. Is like, oh, I'm not, I don't know the Dewey Decimal System. I'm not doing the end notes. I'm not checking my Don't do that. Like, you need to go back and actually do the work. When you write that paper, do the work. Don't let it do all the work.
We have a lot of students in our nursing program that use AI. And I always tell them, AI is not going to be there for you if you don't learn it through the process of reading it and writing it down, making notes. They're not going to be there to save your hiney when you're taking care of a patient who's becoming unstable. You're going to be like, I can't remember. I didn't learn anything.
Yeah, the human mind, you really need to write it down. You need to read it. If you shortcut it and just get the answer without doing the work, it'll burn somewhere down the line. You're gonna get burned.
Yeah.
So
you can't retain that way.
Yeah, you really have to do the work. If you're gonna get that degree, you're gonna get that certification. Take it serious and really learn it.
Yeah, I tell students when they come in my office because. Whether there's an academic integrity issue. And I'll say, if this was art school and you were trying to get a bachelor's of arts, I honestly wouldn't care if you remembered this stuff, meaning who painted the Mona Lisa? Okay, go look it up. But when you're taking care, like you just said, a human life, you better know how to critically think and use clinical judgment. How do you take the pieces of data? Oh, his blood pressure's 20% lower than it was a couple of hours ago. That should get you to think something's going on. Are they bleeding internally? What is the problem here? And investigate. Otherwise, the patient will probably die.
Yeah, you need to really have that holistic, full point of view. You may have situational awareness and with the knowledge of doing like the 10,000, 20,000 hours of rigor. So that you actually have that knowledge. You have the critical thinking. You have the ability that when you see that red flag, it's a red flag.
Yes. And you get help.
You know what the options are.
Yes, exactly.
But I want to thank you again for being here. It's really critically important that we have kind of conversations like this that go to this level where people can really think about, wow, I really do need to take some responsibility for my own healthcare and ask some, hard questions. It might make me feel uncomfortable that I'm challenging my doctor because I've never done that.
Yeah.
Or I'm challenging the nurse because I've never done that. But I'm not doing it to be a jerk. I'm just trying to take care of myself.
Yeah. My goal right now, medical mistakes are the third leading cause of death. Heart disease is number one, cancer, and then medical mistakes. My goal is if we can get that to number 10 or down to zero harm. It's going to take all of us pulling together, though, and working together and recognizing the problem so that we have these solutions to fix it.
I'm glad that you're out here doing this. And I do encourage people to click on the link there that we have on there. You'll be able to click on it on LinkedIn, YouTube, and Kick. Those are channels we've just been on. And I want to thank you for being on the show today. Thank you.
Thank you.